I think what we'll do, we have, I think, about 20 minutes. That's the time, or is it less? 25. So I think Dr. Chawla will, I'll ask him to first take us through 4 or 5 slides, just to set the ball rolling. And then I'll be discussing and have a few questions, audience poll. And this is something which is a matter of public interest. So, we will be taking your opinions as we go on. And our policy makers, I see quite a few, Dr. Dhiman, the most prominent amongst them, that, he should be able to guide us as to what can form policies for the region, community, and so on. Dr. Chawla, please.
Thank you, Gaur. This is an excellent forum for discussing the future of MASLD. So we know that MASLD is increasing in India, and you have diabetes, obesity, metabolic syndrome, PCOS, and obstructive sleep apnea as important features. When you look at the data of diabetes, it was 5.5% in the community in 1990, 7.7% in 2016, 11.6% in 2021, and a significant proportion of these patients have pre-diabetes. So overall, about 25 to 30% of the Indian population suffers from diabetes, which is an important component of MASLD. Obesity, similarly, is around 40.3%, and this I'm talking about abdominal visceral obesity. In India, MASLD has been reported to be in 9 to 53% of cases, and liver is considered to be at the core. Because of MASLD, affection of the liver, you have cardiovascular events, kidney events, and cancers, which is high in this group of patients. We are all familiar with the natural history of MASLD. Mortality in patients who don't have fibrosis, they usually die of heart disease. But with fibrosis, they die of liver-related events and heart disease. Usually progresses very slowly, except when you have associated alcohol, viral hepatitis, smoking, and pollution. And we all in our clinical practice are seeing an increasing cause of cirrhosis and HCC. Hence, it is the time now to act now and screen these patients today. So the Ministry of Health came out with some guidelines, which Dr. VG was just mentioning. These guidelines have come out from ILBS, where they have said that you involve the community health workers. These people are going to screen patients for obesity, diabetes, do a waist circumference, find out any history of heart disease, diabetes in their family, and anyone who's been noted to have metabolic associated fatty liver disease. And then if any one of these are there, from A&M and ASHA workers, they go to the community health centers where doctors would be there and further tests should be done. And if anyone has a higher level of fibrosis as measured by FIB4 or APRI or NFS, these patients should be shifted to a tertiary care center. So it's important that you screen at the community level, correct diabetes, obesity, associate it with linkage of care, and stratify these patients if they have any evidence of fibrosis. But in order to do this screening, you need to have capacity building and train people for managing these patients and identifying patients who have serious fatty liver disease. So we are all familiar with diet, which we discussed yesterday. One needs to have a portion control, restrict, avoid unhealthy fats, physical activity. Patient education is very important, and counseling. Unfortunately, this education comes through the media in spurts, but it is not a continuous information. In fact, public awareness programs are very few, and they are all held intermittently. One of the suggestions in the guidelines to the ministry was that MASLD Day should be celebrated every 15 days so that the awareness increases, and the BMI concept should be converted into a waist circumference, which is much easier to measure. Movement, Fit India movement in 2019 and Eat Right India movement was started in 2018, but we haven't seen much of it in practice. So this is a busy slide where how you have to train your community health workers and go up the ladder to finally reach the tertiary care center and manage these patients for advanced fibrosis. Here again, the recommendation is that the community health workers need to report to the Ministry of Health or the state organizations every 5th or 7th day. This document came out in 2021, and to my knowledge, nothing much happened, as was said by Dr. VG, except 2 days ago when I read in the newspapers that a lot of districts in the country have started looking at the non-communicable diseases program, and every day the ANMs, the ASHA workers and the doctors who are looking at fatty liver disease have to report to the Ministry of Health. This is a news item that came just 2 days ago. And finally, you're all familiar with the INASL recommendations. You screen an individual, do a FIB4, and look for other parameters. And if the FIB4 is less than 1, in contrast to what is reported in the Western literature, 1.3, just follow up these patients every 2 to 3 years. If it is more than 2.67, that means advanced fibrosis. Refer the patient to a hepatologist or a gastroenterologist. And in between, you follow up these patients and put them into clinical trials. So that is all with what I had to say. Thank you, Gaur.
Can I have my slides, please? I think it's a no-brainer that this is an epidemic which is occurring or unfolding in India. And what Dr. Chawla mentioned is very relevant if you look at it from a doctor's point of view. But for each patient who is coming to a healthcare facility, there must be at least 1,000, if not 10,000 people who are out there in the community who need some kind of motivation to change their metabolic profile, because metabolic disorders is rising to that level. So it's actually moving from the clinic a little bit more to the community. Dr. Bhadoria is a community hepatologist. He will be talking subsequently on the role of pediatric hepatology and MASLD. Am I right, Bhadoria? And I think that that's where the problem starts. In fact, Arun pointed out that it starts from the pregnancy. Can I have the next slide, please? Yeah. Now, this is an audience poll question. Can you put it into an audience poll setup? So the question is, what do you think, each one of you, is the most important reason for the increasing incidence of metabolic disease in India? Is it easy availability of junk food? Is it declining physical activity? Is it high stress levels or success of modern medicine? What it means is that there's a pill for everything. So does that make you a little more complacent and less dependent on the conventional methods of maintaining good health? Can we have the poll question on, please?
What if they want to pick on more than one option?
It's difficult to choose one from the four, but I just wanted to see that which one you think is a priority. So most people feel it's 1 and 2, which means that basically easy access to fast food and I think lack of physical activity. So I think that's the issue, absolutely, declining physical activity. Let's go forward. Next slide. Oh, I should move the slide? No problem. So I'll skip quite a few slides and take you straight to audience poll 2. What do you think are the solutions? Now, I'm talking about the community, not the patient coming to your clinic. I mean, with him, you should obviously do all that we have been talking about. But is it mass public awareness campaigns? Is it stronger government policies? Healthcare workforce training that Dr. Yogesh was alluding to? Or school-based interventions? To you, if you were to actually do something good for your local community, which would be your priority focus? Can we put it as a poll question, please? So I think quite a few people are saying catch them young. Yeah, so I think start with the school. I think it's very sensible actually. I mean, our Hope initiative basically works in schools, and we have made a movie on healthy lifestyle, and that's one of our major thrust areas now. Next please, maybe I'll move my slide. All these campaigns that are going on, by WHO and by different governments and Fatty Liver Day, in fact by Hope Initiative, I'll tell you one of the major challenges is how to make it interesting. Most of the government ads, if you see in the paper, which are long and instructive, they're so boring here. I mean, that's the page that you skip the most easily. And one of the things I learned in Australia was that unless you make something interesting, a patient who's not really having a disease is unlikely to give attention to it. So I think that's where the whole issue would be. And no wonder that why Amitabh Bachchan is called upon to be an ambassador for a whole lot of things which matters, like polio vaccine and so on. I mean, you have to grip the attention, the eyeball, and hold their attention. Now, many of you were yesterday asking about the blue zones. So maybe what I'll do is I'll quickly skip these slides and go to blue zones, okay? Junk food advertising and so on and so forth. These are just some slides to show you the kind of activities which are going on. What do you know, what are blue zones? So can we have this as a poll question? Imagine it as A, B, C, D. Blue zones are regions of the world where people live longer than average, well past 100 many a times. These are seismic regions where earthquakes and tsunamis are more common. They are highly polluted areas like Delhi and Dhaka. And blue zones are those regions where people consume a diet rich in seafood and blue-colored foods. I think all of you would get this right after the discussions yesterday, so I can move on. Should I? Anybody has any doubts? Okay, we'll move on. So I'll tell you what's the story about blue zones. There were two ways of looking at health. One is that you invest through what the medical science is doing, what we heard yesterday. But people in the West, the community, they thought otherwise. They said that enough of modern medicine. Let's find out from the grassroots as to why some people live longer and healthier. So it was the National Geographic, it wasn't a scientific body, which was commissioned to find out which are the places in the world where people live healthy and long. So it was based on the places where there are maximum number of centenarians, that is, people living over the age of 100. And these were the 5 blue zones, okay? Some of you already heard the names yesterday, Okinawa Islands and Nicosia, and there was some place near South Italy, Nicosia, somewhere near Italy, and the Loma Indians in California. So having studied these people, they tried to find out what is common between all of them, because they were very different geographical areas. Their foods were different, some were vegetarian, some were fish eaters, some were not. And, but they all had a whole lot of centenarians, people living healthy and smiling above 100. And these were the power 9. So there were 9 differences between blue zones and the rest. So they move naturally every day, a lot of movement. They have a sense of purpose, community purpose, keeping routines to de-stress, eating more plant-based whole foods, consuming alcohol moderately, if at all some do, being part of a community, and keeping loved ones close, and being surrounded by people with healthy habits. Now, it's very community-based activity, close communities, okay? Now, this is what happened, and then they also found out what was common amongst their diets. We will discuss that later on, but there was this beautiful book, The Blue Zone Solution. And now, those of you who are interested, now there are certain blue zone regions being created in the affluent part of the world where people can go and try to live life like in the blue zones. There is one called Yo1 in Catskill in New York, for instance. Expensive way, and it can't be long lasting. This is the kind of food that they eat. So it's basically whole food, grains, fruits, vegetables, no processed foods, no packaged foods, no refined sugars. I think that that's a major difference with all blue zones, okay? So so-called modern way of life has not touched them badly, and this is how things are. But one thing that is of interest to you, these were natural 5 blue zones. The one blue zone which got included recently is the 6th blue zone, and that happens to be Singapore. And Singapore is a developed nation, town nation. And you know, they did it by trying to put policies in place. And these were some of their policies: walk, don't ride. So they give workers extra money or incentives for walking to work rather than taking a car. Keep loved ones close. So if you keep your elderly parents with you, they give you incentives from the government. Sense of belonging. So they're very proud about their region, community. You know, I mean, it used to be earlier on with churches also. So people would have that community of churches all doing the right thing. Our Hindu temples also did that. And then opt for healthy habits. So if you find some senior people doing something, there is a tendency to emulate them if you respect them. And access healthcare. So this accessing healthcare was not part of the previous 5 natural blue zones, but that's in Singapore. So you have very good access to universal health and very strict laws. So all of you who have been to Singapore know that. So with that, I'll actually stop here. But basically now I'll pass it on to Dr. Bhadoria, with your permission, to talk a little bit about what needs to be done when children are growing up, because they are going to be the potential NAFLD patients when they grow up.
Thank you so much, sir. So I think it's important to understand about childhood obesity. Since yesterday we are talking about life cycle approach, everything starts very early. So the task given to me is to tell you about childhood obesity. We all know it's an important risk factor for non-alcoholic fatty liver disease. There is 5 times higher chance of a child who is having obesity during childhood to get a fatty liver and other non-communicable diseases during adulthood. From India, there is a systematic review and meta-analysis which was done recently, including 21 studies from 2003 to 2023. It documented that the burden of childhood obesity was around 8% and overweight 12%. So around 20% children, they have extra weight, overweight, and they were at high risk of developing non-communicable diseases. So it's multifactorial. And in India, as mentioned by Dr. Yogesh Chawla, sir, we have multiple national initiatives which are trying to keep, the weight under control and to get, fight back these non-communicable diseases. Eat Right India, Fit India, and multiple other things which I don't want to mention in the interest of time. So as mentioned by Dr. Arun Sanyal yesterday in his slide, both low birth weight and high birth weight, large for gestation age, both are at high risk of getting non-communicable diseases and also non-alcoholic fatty liver disease also in the future. They both are at high risk, both have higher odds of getting these diseases. So India is suffering from double burden of malnutrition. So our health system is fighting both for undernutrition and overnutrition simultaneously. We have different programs which are taking care of both things simultaneously. And we know that both are unhealthy and both end up into, getting some health issues, health problems later on. So just not taking much time, I'll say we need a holistic life cycle approach. And as mentioned by you all also during the poll, that starting early in the school, I think will be a good initiative, doing health awareness, health screening, not only with children, but also involving their family members, as mentioned in some data that it's in the family, as mentioned by SP Singh sir also. If a wife is suffering from fatty liver, husband is also suffering from fatty liver. So it's in the family, their habits. So if a family is having healthy habits, the chances of the whole family being healthy is there, and even the child will be healthy. So starting in the school with school health programs, I think will be helpful and will, maybe break this life cycle unhealthy practices in future. Thank you so much.
Yeah, I think.
Dr. Choudhuri has said what I've seen in between also. The government laws and the policies, they are very, very important. And I had an experience in treating chronic hepatitis C at the public health level also. So what are the domains that one should have as far as the policies are concerned? The first thing is that the guidelines should be in place. They should not only be the diagnostic or the treatment guidelines, but also the operational guidelines also. So that the policy should be clear at the level of the government or at the level of the associations also. For example, we have ISG, we have INAZL also. So these are very, very important things. The guidelines should be in place. And second thing is that there should be civil awareness. That means civil society engagements should be there, and government funded awareness program should be there. And the third domain, I feel, epidemiology and the data. So whatever you going to deal at the national level, we must have the data actually. That is very, very important. And we should have the population-based epidemiological assessment funded by maybe the ICMR, many other things, or even directly from the government also. And MASLD or the NAFLD detection, awareness program should be there, and particularly the screening of the specific population, for example, obesity or the diabetes also. So these are the policies that need to be in place also. And similarly, and lastly, that the NAFLD care management also that require the multi-direct disciplinary approach also. So what I'm trying to say, that if we have to tackle the NAFLD at the national level, whatever Dr. Choudhuri has said, I think that is the basics that we have to follow. The audience poll says that school interventions are important. There is no doubt about it actually. There has to be policies actually, how to deal all these non-communicable disease, and particularly the obesity, diabetes, and the NAFLD, and what is the exercise level and what is the diet also. I think we need to have some kind of the policies.
I think following Professor Ajay Duseja's vision that the childhood obesity should be fought, we just initiated the INASL ROCO project, but it's still going on a slow gear. I'm trying my level best to put it on a momentum scale. So in engaging the Rotary International directors and all the governors, probably in a year's time, we'll be able to, all Rotary clubs should take it up in the forthcoming year to all the, school children to create awareness on healthy foods and also regular exercise and fighting obesity. So apart from identifying those obese children and getting a counseling done, that is our mission. So over to Professor Duseja for his work.
Yeah, thank you. I think I'd just like to add maybe two things. One is we are all talking about the education and awareness about the healthy lifestyle. And that has to begin obviously at a school level, decreasing the childhood obesity, but not only at school level, I would say in general, this should be for the whole community, the education about the healthy lifestyle. And when we say healthy lifestyle, everybody knows that. So in that direction, it's a huge task. Looking at, targeting the whole community, it's a huge task. So how do we do that? So in that direction, as said by Dr. VG, the INAZL had taken one initiative. This is called a ROCO program. ROCO in Hindi we know is to stop. So ROCO is that this is the Inazal Rotary initiative for combating childhood obesity and fatty liver. So what we are doing is that we have now identified, this has started from the south in some of the zones, and we have taken the, so it's really not possible for Inazal to, do this. So we have taken the help of Rotary International, and now we are trying to identify the zones in different states, and with the help of Rotary International, we've started going to the schools, and as a first step, we are now trying to look at how many children have overweight or obesity. You heard the figures of around 20% of these children are overweight or obese, but then we don't know because our initial figures are different. So I'm still not revealing the data, but then I'm telling you our initial figures are different, and it may vary from state to state and zone to zone. So we need to identify, but that's not there. What is the outcome? What will happen once we know the overweight and obesity? The next step is this, as I said, the education will come in, that then we need to sensitize not only the children but their parents about the ill effects of overweight and obesity, which in one of them obviously is fatty liver, but it's not only fatty liver. It's it's a multi-system involvement because of the overweight and obesity. So that is the next step that we will need to sensitize. So it's a small step by Inazal, but as I said, I think slowly it will grow. And another step Inazal has taken is that we have formed, of the different task forces we have formed another task force, and this task force is called the Task Force on Preventive Hepatology. We're still working, and I'm acting as a chair for that, and Dr. Bhadoria is the convener for this task force, and we have some plans with us that how do we, it's the prevention of all the liver diseases, not only MASLD, may it be ALD, may it be chronic viral hepatitis, MASLD, everything. We know that prevention is the key, but then again, these are very, very difficult tasks, and my humble request for everybody would be to contribute and help us, how can we, take these task forces. The last thing which I would say about the MASLD is, I think we had some discussion yesterday. The problem is that all fatty liver being such a, the magnitude of the problem is so much that all fatty liver or steatotic liver, they all get clubbed into one. I think that risk stratification is very, very important. We need to identify so-called, we were discussing yesterday, 80% will be the slow progressors. They may not have bad outcome maybe throughout their life, but then those 20%, those who are rapid progressors, we need to identify them. Simple things, maybe age, metabolic risk factors, obesity, diabetes, something needs to be done. How do we, look at those, risk stratify them at the community level, and then from the community, maybe through the national program which has not been placed, but the problem is, I think it is still not, at the ground level, things are still not working. So I think we still have to identify these people, those who could be rapid progressors, send them to the secondary or tertiary care level so that, early care can be given to them. Thank you.
Thanks, Professor Ajay. So I'm going to ask you a question. How many of you really believe that childhood obesity will progress to complications in adulthood? Please put up your hands. Wow, all of them. So, right. The next question is, how many of you are interested in doing a small project in your own town? So, approaching the Rotary clubs, your local Rotary clubs, and taking it to the schools. It's a very simple thing that we have done, the INASL ROCO, is you just visit the website. It's beautifully done, thanks to Zydus and Parul. So beautifully maintained. So there are a lot of tips, healthy eating habits for children, healthy exercise pattern, everything is there. All you have to do is just go to the schools, ask the schools to take the height and weight of these children and upload it in the Excel format, in the online format of the inaslroco.com website. Very simple project. And then you can create awareness. So how many of you are willing to do this in your local areas? Please put up your hands. I mean 50%, but I would request, my humble appeal, 100% of you probably can contact the local IMA or Rotary and take it with them, handhold, and then also probably go and create an awareness in the schools. I thank GC for putting me as a moderator here.
Do we have enough time? That's all?
I think we are over.
Okay.
Time, I don't know.
In that case, I'd like to thank everyone. Would we, anyone in the audience would like to make a comment? Just 2 comments.
This ROCO program by NASL and Rotary is a very good thing. At least the first step is a very good thing. But before we go on to the next step, that is identifying this, I'm not audible? Yeah. No. Okay. This ROCO program is very good. At least the first step is excellent. But before we go to the next step, I think we should think about it a bit more, get a positive feedback from the powers that be. Because nowadays you hear every day about DSH and suicides in children and all that. Oh. Okay. Nowadays you hear so many children committing suicide, DSH. Once you tell them that they are obese, that is a very bad thing for the child to hear. And if you go in a peer group, that makes it even worse. So I think we should have a think tank about it, and also we should, okay, we'll just finish. We should get the governments also to agree on this. Otherwise, it could be a dangerous thing.
Kindly make a short comment.
Since Blue Zone seems to be the buzzword and Blue Zone diet and lifestyle is going to be probably the flavor, I must admit that all these enumerations that you made are relevant. But 3 things stand out to me prominently. One is all these centurions breathed fresh air of either Ural Mountains or the ocean breeze. Second, they were all non-vegetarians. The first one is denied to us by the environment. The second was denied to us by the panel yesterday. The third one, all of them drank alcohol, of locally brewed alcohol. I'm sure by the end of this session, this will be totally prohibited for us. So I think we have to be a little moderate in our recommendation so that instead of changing from a Mediterranean diet, Mediterranean lifestyle to a Blue Zone diet or Blue Zone lifestyle, we should be using moderation as the keyword. Because the disappointment in the face of the person who is denied alcohol is really heartbreaking.
Yes,
I'm a
ma'am.
teetotaler, by the way.
Last comment, please.
Yeah. I just want to say one thing. If we don't have healthy habits, children won't be healthy. We ask them to take ice cream and chocolate as reward. We don't take them to playground and play with them. So there is something wrong with our society. We are not concentrating on the right things. We are going to moon, but we are not saving our planet. So we have just changed the definition of the success, which is very, very wrong. It doesn't include the society. It's just individualistic. So this is one thing. And about Singapore, they provide low-cost housing to everybody, and they have a very high tax on cars, so that the people won't buy car and they will use the public transport and walk. So it's a very complicated thing. There's no, of course, the children should be catch young, but we should dissociate pleasure from eating. Then only things will go in the right direction. Thank you.
Thank you, ma'am. I think we'll close this, and I'll invite Dr. Ashish Kumar.
We completed recently 100 years of KM Hospital. We thought we should do something for the public. As everybody knows, NAFLD is a public hazard, public health problem. The only way to bring it to the attention of people is to have celebrities involved. We can treat them. We want people to come to us, that is what is important. And that's why we had Mr. Amitabh Bachchan as a brand ambassador for NAFLD. KM Hospital already has started the OPD for NAFLD. Idea is to try to, if you have got, say, Kamal Hassan or Rajnikant or Vijay Tendulkar, or somebody talking about NAFLD in every state of this nation, I'm sure there will be enough of awareness. Idea is to make 80% of the doctors don't pay any attention to fatty liver. What are we talking about layperson? Just make them understand fatty liver is a disease which is going to kill you. Then only they will come to us, and then we can do something about it.
Thank you very much. Dr. Ashish.
Yeah, thank you, chairpersons, moderators, and panelists for this session. I'll summarize it, but meanwhile, you can come to the center of the dais and have your photographs taken.